Bismillahirrahmanirrahim. I would like to thank Professor Khaled for organizing this wonderful conference. وهي طبعا التيم اللي رائع اللي بيشتغل معانا في الاورجنايزيشن of the conference الحقيقه جميل جدا. I would like to thank the chairpersons for accepting this. Today I will talk about something I hope it is not that heavy. Why we need to collaborate with pulmonologists. There is no more one-man show. Collaboration makes success. So we need really everybody, especially the pulmonology. Hematopoietic stem cell transplantation, why do we call the pulmonologist? Hematopoietic stem cell transplantation includes any procedure where hematopoietic stem cells of any donor or of any source are given to the recipient with intention to repopulate or replace his hematopoietic system totally or in part. There are more than There are more than 50,000 transplants that are carried out annually worldwide. There is a picture that's not present. Bone marrow transplantation or hematopoietic stem cell transplantation are done for many neoplastic disorders, especially hematological malignancies, and for some solid tumors as neuroblastoma. Also for non-neoplastic disorders, especially aplastic anemia, chronic hemolytic anemias, several autoimmune diseases, immune deficiency syndromes, and some inborn errors of metabolism. The sources of stem cell may be either autologous, where the patient is his own donor. The cells are collected from the patient, then processed and cryopreserved, while the patient, especially the oncology patient, receives his chemotherapy, then the cells are re-infused into him to repopulate the bone marrow. Or what we do in our unit is allogenic, where another person who is HLA-matched compatible donor is the donor. Sources of stem cell may be from the bone marrow harvest, from peripheral blood stem cell, or cord blood stem cells. The cells are collected while the patient is taking his chemotherapy to ablate his immune system mainly, and then the cells are re-infused and start working. Of course, no process comes without complications. Complications for allogenic and autologous. The main difference is that allogenic has an exclusive problem with chronic and acute graft versus host disease. Now we come to pulmonary involvement. Pulmonary involvement starts even before the transplant, as pre-transplant pulmonary function testing is routinely performed as a baseline reference in anticipation of potential pulmonary complications. Abnormal pre-transplant pulmonary functions correlate significantly with increased risk of post-transplant pulmonary complications, so pre-transplant assessment is very important. Pre-transplant restricted lung disease predicts poor survival due to pulmonary complications, and abnormalities in pre-transplant pulmonary function test may warrant consideration to reduce the intensity conditioning program if possible. But the post-transplant pulmonary abnormalities should not be used alone for determining the eligibility for hematopoietic stem cell transplant. When we come to post-transplant pulmonary complications, we come over here to some infections and non-infectious problems. And the infection and the complications can be classified where around pre-engraftment, before the bone marrow cells and the stem cells start to work. In the early post-transplant period, this is the first 100 days, and in the late post-transplant period. In the early part, which is the pre-engraftment, bacterial pneumonia, respiratory syncytial virus, and invasive fungal pneumonia are the most common. After that comes some viruses as herpes simplex, varicella zoster, and CMV, also pneumocystis pneumonia and fungal pneumonia. When we come to non-infectious complications, and this is the main part of my talk, we come early to idiopathic pneumonia syndrome, pulmonary edema, diffuse alveolar hemorrhage, engraftment syndrome, In the first 100 days after engraftment, we can see acute graft versus host disease, pulmonary cytolytic thrombi, acute vaccination pneumonitis in patients receiving total body radiation, idiopathic pneumonia syndrome. Late post-transplant, we find chronic graft versus host disease, airway syndromes, post-transplant lymphoproliferative disorder, venous and renal disease. Non-infectious etiologies are responsible for an increasing percentage of pulmonary complications in pediatric hematopoietic stem cell transplant recipients due to better transplant technique, improved supportive care, more aggressive treatment, and prophylaxis of infection. Many of these conditions present with non-specific symptoms mimicking infectious disease, so the differential diagnosis here is very important. Ruling out infectious causes of pulmonary symptoms is crucial, since the only available treatment for many non-infectious conditions is increased amount of immune suppression. Pathogenesis is often multifactorial and may in some cases involve focal infection. To group the pulmonary complications, we can group them into 4 main groups: treatment-related complications, idiopathic pneumonia syndrome and related disorders, pulmonary vascular complications, and graft versus host disease with its related disorders. To start with, we start with treatment-related complications. Upper airway complications, they occur early and mainly in the form of mucositis and aspiration due to vomiting. Pulmonary edema and pleural effusion may occur. Pulmonary edema occurs mainly due to aggressive hydration, but there are also infection, total body radiation, and chemotherapy can produce it. Pleural effusion occurs due to aggressive hydration, veno-occlusive disease, recurrent malignancy, pulmonary infection, medication impact, or surgical complication. Now to come to the airway syndromes. The airway syndromes occur due to surgical procedures or central line placement, but also can complicate some of other pulmonary problems like chronic obstructive lung disease from bronchiolitis obliterans syndrome or restrictive lung disease due to idiopathic pneumonia syndrome. Radiation pneumonitis and radiation fibrosis occurs in cases that we receive total body irradiation in conditioning regimen, and this we don't use much nowadays. The incidence and severity is related to the total dose of radiation, how the dose was fractionated, the type of radiation used, and the volume of lung exposed. The effects may be subtle and appear late after 2 to 3 months, and treatment mainly with steroids. Transfusion-related acute lung injury, it's not that common, but we see it. The onset of bilateral infiltrates and PaO2 over FiO2 ratio less than 300 without evidence of left atrial hypertension. It usually develops within 6 hours after receiving any blood product. The treatment is mainly supported and most patients recover in 2 to 4 days. The medication-related lung injury is very important in the many forms: inflammatory interstitial pneumonitis, sometimes lung fibrosis. The inflammatory interstitial pneumonitis occurs due to hypersensitivity type reaction, may appear at any time, even after the first dose of drug, or months or years after completion of this drug. Signs and symptoms develop over hours to days. They have non-productive cough, progressive dyspnea, low-grade fever. Chest X-rays show interstitial pattern with or without infiltrates. Pneumonitis usually resolves with discontinuation of the offending drugs or with steroid therapy. Pulmonary fibrosis due to graft-cyst takes more than 2 months to occur. Cyclophosphamide, bleomycin, mitomycin C, busulfan, these drugs that we all use are implicated. This drug-induced pulmonary fibrosis usually progressive and shows fatigue, dyspnea, non-productive cough. Pulmonary function tests usually demonstrate restrictive lung pattern with decreased diffusion capacity to carbon monoxide. Biopsy sometimes is required to be diagnostic. Corticosteroids may be used, but the damage happened is irreversible. The post-transplant lymphoproliferative disorder is another treatment-related complication. It's related mainly to the presence of B lymphocytes latently infected with Epstein-Barr virus, together with intake of severe and massive post-transplant immune suppression. Lymphadenopathy is the main manifestation, but there are sometimes symptoms. But systemic symptoms of PTLD may occur ranging from viral-like illness to fulminant sepsis-like conditioning. Respiratory symptoms occur even in the absence of direct lung involvement. It usually appears within 1 to 5 months after transplant, and this is a period of heavy immune suppression. Reduction of the dose of immune suppression is sometimes enough for treatment, but some patients need to take monoclonal antibodies like rituximab or radiation, and rarely surgery. The second group is the idiopathic pneumonia syndrome and related disorders. Idiopathic pneumonia syndrome is a clinical syndrome of diffuse lung injury after hematopoietic stem cell transplantation in the absence of identifiable infectious cause. And this is very important. Most of these complications show coincides with this picture of infection. And the most important item is to exclude infectious cause in order to go with this treatment. Previously known as interstitial pneumonia, contributing factors include pre-transplant conditioning regimen, of course, with several drugs, immune-mediated inflammation related to lung injury, and possibly occult infection. Two main diagnostic criteria occurred with evidence of widespread alveolar injury with restrictive pattern in pulmonary function test and the absence of active lower respiratory tract infection, better proved by bronchoalveolar lavage and the transbronchial biopsy. Treatment of idiopathic pneumonia syndrome generally includes supportive care, empiric steroids, although the efficacy of the steroids is not proven. The new treatment is the use of anti-tumor necrosis factor alpha, etanercept, or the monoclonal infliximab. They can be useful for, in addition to the standard immunosuppressive therapy. Another complication mimicking idiopathic pneumonia syndrome is the diffuse alveolar hemorrhage. It occurs in 4 to 6% of pediatric cases of hematopoietic stem transplant, characterized by cough, hypoxia, progressive dyspnea, diffuse interstitial and alveolar infiltrates, and of course, of absence of detectable infection. It has no clear risk factors, and hemoptysis occurs mainly in the pediatric age group. Symptoms typically appear in 1 to 4 weeks after transplant, with the time of working of the new stem cells, which is the time of engraftment, and it rapidly progresses. Diffuse alveolar hemorrhage is suggested by bronchoalveolar lavage that reveals progressive blood-air fluid as seen in the picture. The etiology of diffuse alveolar hemorrhage is unclear, although inflammation and cytokine release seem to play a significant role. The treatment is mainly with steroids and recombinant active factor 7. Engraftment syndrome, it's all called the peri-engraftment respiratory distress syndrome. From its name, it occurs around the time of working of the stem cells. When the stem cells start to work, this is called engraftment, especially the neutrophils. At the time of neutrophil recovery, we can see here there is cytokine surge, and the cytokine surge causes increased capillary permeability that cause findings from mild infiltrate to non-cardiogenic pulmonary edema up to acute respiratory distress syndrome. Engraftment syndrome typically occurs with autologous peripheral blood stem cell transplantation. We don't see it much in our cases of allogenic transplant. Supportive management is the standard therapy, but the mortality, unfortunately, is up to 23%. Eosinophilic pneumonia is rare, and it can be treated with steroids. Now come to pulmonary vascular complications. We start with pulmonary cytolytic thrombi, which is found almost exclusively in the pediatric population. It's a pediatric disease occurring in the 3rd month after transplant mainly, with fever, cough, chest pain, progressive respiratory distress. The chest CT demonstrates the characteristic discrete peripheral subpleural nodules and the opacity of varying size, as we see in the picture here. They are difficult to distinguish radiographically from some infections as fungal infections. The definitive diagnosis is by lung biopsy, demonstrating occlusion of vessels with cellular breakdown. Pulmonary cytolytic thrombi represents histological manifestation of acute graft versus host disease. Patients show improvement with increased amount of immune suppression. Pulmonary thromboembolism may occur because onset is very acute, diagnosed by CT and or angiography, and treatment may be supported with urokinase and heparin. Pulmonary vein-occlusive disease is a rare, universally fatal complication. Dyspnea, cardiomegaly, radiographic infiltrates, pulmonary hypertension occurs in the second month post-transplant, mainly seen in oncology patients because it is mostly secondary to very heavy in conditioning regimen with cytotoxic drugs, and the diagnosis often made post-mortem. Pulmonary arterial hypertension occurs only in sporadic cases, and treatment with prostacyclin has been tried. The last, but most important part of the non-infectious complications is the graft versus host disease and its related disorders. We start with bronchiolitis obliterans syndrome, which is the most common late non-infectious pulmonary complication. It occurs in 5 to 30% of transplant patients, diagnosed months to years after transplant, with partial or complete obstruction of the small airways due to inflammation or fibrosis. Pulmonary function tests showed new onset airflow obstruction with decrease of FEV1 and FEV1 over FEPC ratio. Chest radiographs show hyperinflation, and CT, as is seen in the picture, demonstrates parenchymal hypertension, air trapping, and this commonly bronchial dilatation. Bronchoscopy and the bronchoalveolar lavage are used to exclude infection. They cannot be used as a diagnostic procedure due to the patchy nature of the disease. So surgical biopsy sometimes is the definitive diagnosis, but maybe it's very difficult to be done because of the bad condition of these patients, because they have severe obstructive airway disease. Given to these diagnostic difficulties, obstructive lung disease after hematopoietic stem cell transplantation, in the absence of evidence of infectious cause, is generally considered to represent bronchiolitis obliterans syndrome. But it has been to have, it is some differential diagnosis, because asthma may give the same picture. The patients come with severe bronchial obstruction, and he may not be asthmatic before. But many of our patients are having picture like asthma before transplantation, especially the immune deficiency patient, like hyper-IgE syndrome, like that. So we should differentiate between the asthma, and the asthma can be transmitted from the donor to the recipient through transmission of allergen-specific IgE or other factors. Asthma is distinguished from bronchiolitis obliterans syndrome by the reversibility of airway obstruction after administration of bronchodilators, and this is very important. Treatment of bronchiolitis obliterans involves high-dose pulse steroid therapy, azithromycin, that now is very promising, also infliximab, heavy immune suppression, and intravenous immunoglobulins. Mortality is still high in severe cases, and some cases require lung transplant. The last complication is the bronchiolitis obliterans organizing pneumonia, or what's called the cryptogenic organizing pneumonia. This presents more like pneumonia than airway disease within the first 2 to 6 months after transplant. Extensive infiltration of granulation tissue with alveolar ducts within alveolar ducts, consisting of fibroblasts and matrix of loose connective tissue. Bronchiolitis obliterans organizing pneumonia is exclusively an alveolar disorder. There is no prominent bronchiolar damage. It is characterized by restricted pattern in pulmonary function test. It's restricted defect, not obstructive as bronchiolitis obliterans syndrome. 80% of patients respond to systemic steroid, but with frequent relapses. Then the recent use of clarithromycin has shown better response and also less frequent relapses. Some cases may progress to respiratory failure. We have our take-home message. The pre-transplant pulmonary function test predict the possible occurrence of pulmonary complication post-transplant. Pre-transplant pulmonary abnormalities should not be used alone to determine eligibility for hematopoietic stem cell transplant. Although both infectious and non-infectious causes share similar clinical presentation, their management and treatment are much different. So we need really to call childhood hematopoietic cell transplant have subclinical lung dysfunction and thus should be followed closely by a pulmonologist. Thank you.